We're going to go ahead and start. Good evening, everybody. Thank you for joining this webinar, and we're really delighted to have Dr. Lee Alward and Dr. Erin BOESE from the University of Iowa joining us to teach us about clinical gonioscopy as well as gonioscopy in the OR. I think Dr. Alward does not need any introduction. He's like, the gonioscopy man. And so is Dr. BOESE, who's going to teach us about how to skillfully use the gonio lens in the OR. So Dr. Alward, take it away from here. Thank you.
Oh, great. Well, thanks. It's an honor to be there virtually. I had the pleasure of lecturing there in person a number of years ago. Dr. BOESE and I are going to divide this up. I'm going to do the first 3/4 of the talk and just maybe give you some tips on doing gonioscopy to hopefully make you better. I've gotten to watch a lot of people do gonioscopy and sort of seen how you can screw it up or make it better. I've certainly screwed it up too. And then at the end, Dr. BOESE is going to take over and talk about taking gonioscopy skills and translating them into the operating room. Because now in the era of MIGS, gonioscopy, direct gonioscopy in the operating room has become a really important tool. So, as you all know, ophthalmology is great. Unlike a cardiologist or a hepatologist, we can look directly at pathology. When the pressure's high, we can look and see, is the angle open? Is the angle closed? Is there a secondary etiology that we can identify, like pigmentary on the left or exfoliation on the right? So why do we do gonioscopy? Why don't we just look in? And that's because light from the iridocorneal angle reflects back into the eye. And this reflection occurs at the tear-air interface where there's a big change in index of refraction. And that critical angle, which I think is a useless fact, but it's something they can ask you on a board exam, is 46 degrees. So if it's steeper than that, in theory, you could look straight in. So the total internal reflection is the principle behind fiber optic cables, that the light travels in a way that it never exits a cable, it just keeps bouncing around. I like this example. I always wondered how my windshield wipers worked, why they came on when it rained. And that uses also total internal reflection. So there's a little sensor on my windshield and raindrop lands, and instead of bouncing back in, the light is allowed to escape. And then a detector tells it that, and the windshield wipers turn on. So I always worry that this is the only thing people remember from my talk, but I think it's kind of a cool trivia point. So this is me trying to look at the angle of my technician, and no matter what I try, I can't do it. The one exception of that is someone who has a very steep cornea or a big globe like keratoglobus keratoconus. This is obviously very rare. And the view, even in this eye with keratoglobus, the view is pretty terrible. So Salzman is a guy who recognized this. He recognized total internal reflection. And he was the first one who did gonioscopy using a lens. So this was back in 1900. And he used these lenses that were designed to control irregular astigmatism. I just can't imagine how uncomfortable these lenses were to wear, but he used those to get a view of the iridocorneal angle. He first described blood in Schlemm Canal. I find that to be difficult to see, but he was able to see it with this horrible equipment he had back then. And we should all be humbled that Salzman back 110 years ago made these amazing paintings of what he was seeing in the angle. So if he could see that with a thick lens and whatever contraption he was using, instead of the slit lamps that you and I get to use, we should be able to get a good view. So gonioscopy has been around for over 100 years. At least in the US, it's not used enough. A study by Dr. Paul Lee's group looked at 193 glaucoma patients, and on their initial exam, only half had gonioscopy. And these are people with glaucoma. This is not just random people in the clinic for a contact lens fitting or something. So gonioscopy lets you look at the pathology. So if you have intermittent blurred vision years after cataract surgery, you might see, if you're lucky, you can see the wound bleeding like this. This is Swan syndrome, named after a former Iowa faculty, so we had to shout that out. Somebody with angle recession has lots of iris processes, and you can actually see where the processes begin and end. See the extent of his angle recession that way. So I'm going to show you a few gonio videos here at the beginning. Just, I really want you to get excited about looking at the angle because it's a beautiful view. And as your skill improves, you'll be able to get views like this. So here the processes are beginning again, lots of processes, and here they're gone. And so that's where the recession starts. Neovascularization with these fine vessels in the angle. Somebody whose eye looks pretty good, kind of red, kind of engorged vessels, might be on bromonidine. But when we put the gonio lens on, you can see blood in Schlem canal from high episcleral venous pressure. This eye looks pretty good too until he looks down, and when we look at his angle, we can see that it's completely full of melanoma. Somebody with ice syndrome, you can see the little bumps on the iris, so-called iris nevus, even though they're not nevi. And then the hallmark of ice syndrome are these very tall PAS that actually extend past Schwalbe line, which we'll see here in a second. You can see those areas of normal iris pooching through this membrane. And then you can see these high iris, these high synechia that go way up onto the cornea, which is a hallmark of ice syndrome. And other things that doesn't happen unless there's a break in the corneal endothelium. This is a patient with aniridia. Just kind of a cool video. Interestingly, they don't have pannus and they don't have iris hypoplasia because there's no nystagmus. So they're really missing the worst parts of aniridia. You can see that the lens has resorbed. And in the on gonioscopy, you can see the ciliary processes there and just this very tiny stump of iris. This is somebody with bubbles in the angle. People always get the silicone, but it's the wrong angle because of gravity. So this is perfluorooctane in the angle. And this is a patient with spherophakia. So angle closure in the face of high myopia, you should be thinking spherophakia. It's like a bit like a volcano. And this is what they look dilated. And Axenfeld-Rieger syndrome with a prominent ring in the peripheral cornea that we have proven, Dr. Edward and I have proven is not Schwalbe line. And lastly, there's just this 17-year-old girl with what looks like a scary lesion on her iris that on gonioscopy looks even scarier. So I show you all these videos just to kind of get you excited that, man, gonioscopy is pretty neat. You get to see some amazing pathology and really cinch the diagnosis in many cases. So it's so much more than just a way of saying that the angle is open or closed. But even if that's all you wanted to know, it's still the best tool. In this study from India, from Singapore, I'm sorry, they looked at patients dilated with tropicamide. They were prophylactically given acetazolamide to help blunt any pressure spikes. And some of them had a, a marked pressure spike. Several had a mild pressure spike. And then they went and looked at all the things that they could have studied to predict that. And the one thing that stood out was their gonioscopy grade. At that time, biomicroscopy did not make the diagnosis, although obviously ultrasound is getting much, much better. So there are two main types of gonioscopy lenses. There are direct lenses in which you put a domed lens like this Kepi lens, something much steeper than the critical angle, and that allows you to look directly into the angle. And there's a whole series of these, and there are many, many more now because of all of the angle-based surgeries that Dr. BOESE is going to talk to us about. So direct gonioscopy was the way gonioscopy was done back even before my time. And in order to do it, you had to take the patient to a special room, lie them down, put a Kepi lens on their eye, and had to have a special slit lamp that was hanging from the ceiling, counterweighted. And so it was a really awkward thing. And the Van Herrick technique, which we'll talk about in a moment, the Van Herrick technique came out because you didn't want to do gonioscopy on everybody. But now with indirect lenses, like what you have in your pocket, we can do gonioscopy. We should do gonioscopy on everyone with any form of glaucoma. This is me doing direct gonioscopy on a baby with the Swan-Jacobs lens. Obviously, the baby's sedated. So there are some advantages. You get a panoramic view. You're easily able to change the angle of view. You can compare the two eyes easily, but it's inconvenient. And as we all know, anything that's inconvenient, we tend not to do often. There's no indentation or corneal wedge, which are two tools that I'm going to talk to you about here in a minute. And you can't vary the magnification. But it's great for angle surgery. And this is me doing a goniotomy. And in the era of MIGS, direct gonioscopy has become really important again, almost cool. And so my cooler colleague, Dr. BOESE, will talk about that. So indirect gonioscopy is what we use in the clinic. So light from the angle strikes a mirror and is reflected back at you. It is parallel with the optical axis. And there are two main types of lenses, the Goldmann style 3-mirror lens style and the 4-mirror lens style like the Zeiss or Posner or Sussman. So the Goldmann lens compared to the 4-mirror lens is easier to use. The view is beautiful. It's great for photo and laser. Again, it's inconvenient. You can't use it to indent. And it really interrupts with your clinic flow. So, if you see a patient, do vision pressure, slit lamp, gonioscopy, then you send them off for fields and photos and OCTs, etc. If you've done Goldmann style gonioscopy and you put methylcellulose on the cornea, you'll get lousy exams for the rest of the visit. So it's not something that I can use in a normal clinic. However, if I really need to see something, I'm lost with my 4-mirror lens. It is a better view. And we use it to get all these videos that you see. We use a thing called a MagnaView lens, which is a 1-mirror lens. So it's a great lens to have around, but for your day-to-day use, I would use one of the 4-mirror lenses. And if you are going to use a Goldmann lens, you use the short mirror. That's the one that points at the angle. So 4-mirror lenses are convenient. It's easy to see all 4 angles. It's great for indentation, which we'll talk about. It's harder to master a little bit, and it requires a light touch. So corneal folds should not be part of your normal exam. And I know that for my residents and fellows, if they're looking through the side scope watching me do gonioscopy, it's kind of annoying for them because I hold the lens so lightly that air is always flashing under the lens. If you hold it with a death grip, you're always going to have folds and you'll never see a narrow angle. Again, you can see most of the angle without rotating the lens. And there are two styles, Posner style. The Sussman style, the Posner style has a lens. I'm sorry, has a handle. That's the lens that I prefer. The Sussman does not have a handle. One of my partners prefers the Sussman. I don't really uh, have strong feelings. I think if you are not tall, if you're short, Sussman is harder to use just because you don't have, you're farther away. So this is just talking now about basic exam techniques. We have this canthal mark on the slit lamp, and usually you ignore it. But for gonioscopy, it's important because you need to have the range up and down with the slit lamp, and so make sure your patient's lined up with that. Really important to brace yourself. So my arms are long enough that I don't need to have a block under my arm, but for people with shorter arms, have something under your elbow. Your elbow should never be flying around because you're going to have no control whatsoever. And then I brace my fingers against the patient's face. So really, I'm just using my thumb and index finger to control the lens. The rest of me is solidly in place. And this is really important. When I've watched residents do gonioscopy and they're struggling, it's because they're not braced. Don't flood the eye with light. So if you flood the eye with light, the pupil will constrict and the angle will open. Um, so this is the angle. It's a little bit narrow, and when I crank up the light, you can see that it pulls the iris out of the angle. So use a fairly short beam of light. It should not enter the pupil. I'm not going to talk to you about grading the angle today just because we only have so much time, and every institution prefers a different type of grading system. Here at the University of Iowa, we use a Dr. Space system that incorporates the height of angle insertion, the angular width, and the shape of the iris. But I'll let you read up on that, or you can go to my Gonio website and talk about that. So this is all well and good if the view is easy, but what if the view is challenging? You look in and you have no idea what you're looking at. And so I'm going to talk about a couple of techniques that might help you be a better gonioscopist. And of these 5 things, I'm going to highlight the corneal wedge and indentation. So first, I always examine the inferior angle first. I'm looking in the upper mirror at the lower angle because it's the deepest. Because of gravity, it's the most pigmented, and it's easiest to use the corneal wedge in the upper and lower mirrors. We'll talk about that in a second, but really hard to use the corneal wedge in the lateral mirrors. I never do it. So what is the corneal wedge? This is a sketch of the front of the eye. And what we do with the corneal wedge is we have a bright beam of light offset from your oculars, like you would do for the Van Herrick test, which we'll talk about in a minute. So bright beam of light offset from your oculars. And then in the cornea, you get 2 images. You get a crisp image where it illuminates the inside of the cornea, and kind of a fat, fuzzy image where it shows you the external part of the cornea. And these two travel in parallel until they run out of cornea and they join at Schwalbe line. So corneal wedge is a way to identify the front of the trabecular meshwork if you're struggling, either because the patient has no pigment, like a 13-year-old patient, or a patient has tons of pigment and you don't know what's what. So this is a Lee Allen painting. He always makes the Schwalbe line look like something. I can almost never actually see Schwalbe line. But with the corneal wedge, you can tell where it is. This is a young boy. I would never be able to tell you where his trabecular meshwork started if I didn't use the corneal wedge. But you can see the skinny internal beam, crisp, fat, fuzzy external beam, They illuminate the face of the sclera and they join there at Schwalbe line. Right there. I think I make this magnification a little bit higher here in a second. All right, so corneal wedge, yeah, there we go. And again, I would never find his trabecular, the anterior border of his trabecular meshwork if I didn't have the wedge. Really cool technique. This is somebody who's got all kinds of pigment. You know, what is the meshwork and what is just extra pigment? And by putting on this narrow beam of light, it shows me that this is the start of trabecular meshwork down here. This is all just pigment anterior to the trabecular meshwork, a Sampilaci line. Really, really valuable in this situation. So the thing with the corneal wedge is it's hard to do. And you don't want to wait until you're trying to sort out an eye like this to use it. So if you have a quiet clinic or a classmate who's a contact lens wearer, just take them at the end of the day and try to find corneal wedge in normal eyes and get really good at finding it before you try to dust it off and use it in a mystery patient like this. Another patient, no idea what's going on here. Looks like a really deep angle, right? But then what we find is that that pigment that we see marks the beginning of the trabecular meshwork. This is almost off the screen, sorry, but this is somebody with a very narrow angle. The beams come together just above the iris surface, so very narrow angle, but not closed. And this is one that's close, right? It looks like railroad tracks going off into the distance. So I find the corneal wedge of the things I'm talking about the hardest thing to do. And you need to do it in a dark room with a narrow, bright beam of light. And when I was struggling, Lee Allen did all these amazing paintings that are in my book and in my lectures. And I asked him how he always got a corneal wedge. And he said, have the patient look slightly away from your examining mirror. So you're looking at the patient and you have them, you're looking at the inferior angle. You have them look just a little bit up, and that'll bring your view more up onto the cornea. That way it made a huge difference for me. Practice. So indentation, another really invaluable tool. And the concept here is you have a lens that has a smaller area of contact than the width of the cornea. And so this is an eye that has narrow angles on both sides. And I push in, and this opens up on the right side, and this and the left side stays closed because of synechia. And again, when you look at the cornea, you can see all these folds in the cornea. So corneal folds, you should only see it when you're intentionally indenting the eye. So you need a lens that's small, a Sussman or a Posner style lens. You can see compared to a Goldmann lens, a Goldmann has a much bigger area. And you don't need to use the big muscles on your back to do this. I'm just pushing gently with my index finger and thumb and pushing the iris back. So this is somebody with a very, very narrow angle. When I push, you can see the trabecular meshwork. So this is somebody whose angle's not closed with synechia, but closed with apposition. And again, you see corneal folds there. This patient has this sort of stuff over here. We don't know what that is. And then when we indent, you can see all the way down past trabecular meshwork to scleral spur. So this is an eye that has appositional angle closure, opens really well with indentation. So you would expect with an iridotomy or lensectomy, their angle would be wide open, or would be open, not necessarily wide open. I like this video. This is somebody who, you look and you think, well, that's trabecular meshwork, that's scleral spur, so I'm going to do my laser. I'm going to come kind of blast along here. But when I indent this eye, what I realized is that that actually was not the trabecular meshwork. That was a San line right there. Meshwork is way back here, and and that's scleral spur. So I think I indent everybody I look at pretty much. Partly I like to see the iris in motion. It's just a different view than a static view. This is somebody who is open on one side, closed on the other side, just a video example of the same thing. You can see that when I push, the right side opens up, the left side stays tethered with synechia. When I release, it all looks closed, right? So this somebody probably would do okay with an iridotomy, but is going to be left with some chronically closed angle. Indentation is a great tool for plateau. I think it's better than any imaging tool. And basically in plateau, the ciliary body is forward. And so you have a deep central chamber, but this steep drop off in the far periphery. And so if you did a Van Herrick test, which we're going to talk about in a second, looking at the depth of the anterior chamber, the anterior chamber looks pretty good. It looks fairly normal in depth. But if you can do indentation to really make this diagnosis. So you can imagine if you push down in this iris, it's going to drape over the lens and it's going to drape over the ciliary body and give you this sort of double hump sine wave kind of a view. So here's somebody with a narrow peripheral angle. When I indent, we can see this roll of iris. In your mind's eye, you can see the iris draped over the lens, then draped over the ciliary body. And you can see the trabecular meshwork there. So just a video example of the same thing. As I push, you can see, you can sort of imagine the ciliary body under there holding the iris up and keeping it from just going back like would happen in a normal eye. Another example here. As I indent, you see the corneal folds. I always back up to show you those. And then you see this fullness here in the far periphery. So, you can do imaging to make this diagnosis, but I think gonioscopy is the best tool. So I talked about the Van Herrick. Remember, the Van Herrick was invented way back before indirect gonioscopy, and the idea was to just use a slit lamp to uh, recognize people at risk who might need gonioscopy. In 2025, the Van Herrick should not be used instead of gonioscopy, but it's a great adjunct to gonioscopy. If you're confused and the corneal wedge hasn't helped you, you can use the Van Herrick to estimate anterior chamber depth. And remember, this is why we used to do it. So here I'm bringing this, I think this is Dr. BOESE's eye, actually. Um, I'm bringing this bright beam of light in from the far periphery, and I'm comparing the thickness of the cornea to the thickness of the anterior chamber. So the video will stop here a second, little rulers will appear. So that's the thickness of her cornea. And then the thickness of her anterior chamber is much deeper than, or substantially deeper than that as a myopic patient, right? So if you're doing the Van Herrick, you would assume that this is somebody who has a deep angle. This is someone clearly has had trauma. We've got some tears in their iris sphincter there. And then when we do the Van Herrick in this eye, there's the ruler. And you could park a car in this anterior chamber. It's so deep, right? Super deep chamber. If I get this to stop, we'll see that this is another example of somebody with a deep, normal deep anterior chamber. And then this is a patient whose chamber is really shallow. You would expect on gonioscopy that this angle would be almost closed. So that's the corneal thickness, barely an anterior chamber in this one location, but there are areas where the iris is clearly touching the cornea right there and sort of sporadically through there. And then this is somebody whose angle is closed, right? There is no anterior chamber on Van Herrick in the periphery. So again, it's an adjunct to, it does not replace gonioscopy, but it's a useful tool. And I think I do it on every patient when I'm doing my slit lamp exam, just that's how I'm wired. The other really useful tool is look at the other eye. So the resident might come up to me in the hallway and say, I've got this guy, he's an acute angle closure glaucoma. Can't see his angle because his cornea is so steamy. I always ask them two questions. What's a refractive error? If it's -3, you might want to rethink that diagnosis. And what does the other angle look like? Because if the patient phakic in both eyes and the other angle is wide open, probably not primary angle closure glaucoma. So here's an eye that looks like could be a highly myopic eye or it could be angle recession. And when I compare it to the other eye, you can see that the ciliary body and the image on the left is lighter because there's been a tear into the ciliary body face and there's less ciliary body between you and the sclera. And you can also see that there are iris processes here in the normal eye that have been ruptured in the recessed eye. So these are techniques that I think you should have in your toolbox. And to sum up my part, canthal mark, brace yourself. Don't flood the eye with light. Use a light touch. Can't emphasize enough practice, practice, practice. Watch somebody with more experience and don't beat yourself up if he or she sees things that you didn't. When I was a fellow, I was in Dr. Palmberg's clinic in Miami. And if I finished before him, I would just go watch him do gonioscopy. And he often saw things that I missed as a fellow. So if you're a resident or a fellow and you're not seeing stuff that your faculty is seeing, you shouldn't beat yourself up for it. You should just work on getting some more tools. I have two websites that talk about gonioscopy, gonioscopy.org and the Iowa Glaucoma Curriculum. And I'm going to pass this off now to Dr. BOESE, who is going to talk about gonioscopy in the operating room.
Thank you so much. So as Dr. Allward said, I'm going to kind of transition into how we use gonioscopy in the operating room. And this has become a lot more applicable now because we have so many angle-based MIGs out there. It used to be that really only pediatric glaucoma specialists were using gonioscopy in the OR, and that's no longer the case. So, when I started doing gonioscopy in the OR, I think there's this idea that if you get really comfortable with in-office gonioscopy, that you can translate all these tools over to surgical gonioscopy, and that's not always the case. There are a couple of things that make surgical gonioscopy easier, and that is that you get this direct view. You don't have to work on flipping mirrored images in your mind. The focus is primarily on the nasal angle for a lot of these things. And so, I think that you really need to know what's going on in the rest of the, 360, but really most of your work is going to be done in one angle. And the other thing is there's really no such thing as narrow angles when you're in the operating room, because viscoelastin can open up the angle as long as there's not synechia, etc. But there are a lot of things that make surgical gonioscopy harder. The biggest thing I find is that you're multitasking. In the clinic, your full focus is on getting a really good view of the angle. When you're in the operating room, you're often taking that image for granted. You're focusing more on the surgery that you're requiring the view for. There are other confounding variables in the operating room that you don't have to run into in the clinic. That includes, the blood, whether it be inside the eye or on top of it. We'll talk about that. The cornea, you're more likely to have things like hazy corneas, especially if you're combining these with other surgeries. This is true for both, but different aspects of patient cooperation can be more difficult. The other thing is that there's no orienting landmarks. So some of those tips and tricks that Dr. Allward went through aren't something that you can lean on in the operating room. So I'm going to talk a little bit about tips and tricks, starting with preoperative planning. So you already heard the statistic about half of patients with known primary open-angle glaucoma had documented gonioscopy, and this is an absolute must for surgical planning. And you really, really need to know your anatomy. Again, I said that you didn't have some of the tools. These are some of the similar videos that Dr. Allward showed, but there are angles out there with a lot of pigmentation, or in some cases, no pigmentation. You really have to know exactly which of those pigmented lines or lack of is the trabecular meshwork, because the stakes are going to be a lot higher. Because if you end up going into you can certainly make a cyclodialysis cleft if you go too deep. You can cause Descemet's tears if you go too anteriorly. And it's something that you can plan for ahead of time, and you can really choose your operative candidates accordingly. The other thing is rotation and positioning. So this is right at the start of your surgery and can really make all the difference in the world to make your surgery, whether it be really hard or very easy. And I find that you really need to make sure that the scope and the patient head are rotated enough. You're trying to get a direct en face view of the angle. So I find that if I just tip the patient's head a little bit at the side, they'll often kind of slowly rotate it back. So I actually will end up lifting up the patient's head, rotating it, and then setting it down again. And for whatever reason, that they seem to stay in that position a little bit better. And again, you're looking for this en face view. This is a diagram I adapted from Dr. Shabani, but if you have a nice en face view, you can see how the whole angle anatomy opens up for you. If you're off at a slight tilt, you may still see your angle anatomy, but everything is going to be compressed, and it's going to make all of those landmarks much, much harder. So here's an example where I am not rotated enough. I don't have the patient rotated enough. The scope isn't rotated enough. And just a little bit more, you can end up seeing the trabecular meshwork. This is a nice open angle. I just wasn't in a position where I could actually see the trabecular meshwork. The other thing is not only just visualization, but if you're going in there doing a hook dual blade goniotomy, for instance, it can be really challenging if you don't have that en face view, because you can imagine if you go at it as an angle, you can be skipping it in and out of Schlem canal. And that can be very challenging, but also can put yourself in some dicey situations too. So other kind of a big tip tricks is avoiding things that are going to block your visualization, starting with corneal haze. There are different ideas behind this, but I often like to do angle-based surgery before I do phacoemulsification. The people who like to do phaco first will often say that it's nice to open up the angle more, getting the lens out. But again, if you're using viscoelastic, you're going to be able to deepen that angle, and you're going to have a pretty good landing view no matter what. So in my opinion, I like to do the angle base. I get a clearer cornea at the start of the case. Even if it's a quick phaco case, sometimes you end up getting a little bit of corneal edema that makes angle-based surgery a little bit trickier. Corneal stria is something I see a lot, especially with training. What you're looking for is kind of that same thing like in the clinic. You're looking for a very light hold on the gonioscopy prism. And you're trying to make sure that you have an equal pressure from the outside, your prism, and the inside of the eye. And what happens oftentimes, especially in those early cases, is that I find that residents or something will forget that they're holding the prism, and they'll start leaning on the eye, and you start ending up getting those corneal stria. So, oftentimes for those first cases that I have my residents do, I'll often have someone, like I'll hold the prism for them. And then that way their whole focus is on their surgical hand. There are also hands-free lenses that are available for this. The other thing that I see is that you might have a really light hold on the prism, but if there's not enough viscoelastic in the eye, then you're going to end up with the same imbalance of pressures. And it's not usually that you started out with too little viscoelastic. What usually happens is you end up putting up or down torque on the wound, kind of gaping it open, and you end up burping a lot of this viscoelastic out. And when that's the case, it doesn't matter how light of a hold you have on that prism, you're still going to be imbalanced and you're still going to have that corneal stria or corneal folds, excuse me. Here we can see corneal stria. You can see if you wedge your tool, or in this case, Cahook dual blade, way up to the side of the wound, rather than pivoting within, you can see that these stria radiate from the sides of in the corners of your corneal wound. So when you're working within this, you really want to make sure you're pivoting within the wound and not kind of using the side to side aspect of the wound, because that's another way. And unlike the other types of stria that you're seeing these ones radiate from that corner. And then blood. Blood is something that there are two areas that it's going to really make a difference. One is on the surface of the eye. I think a lot of times when we're making our main incisions, at least I find myself making these little nicks on the blood, on the conj, where you have a small amount of bleeding, and this would never affect a phacoemulsification. However, what happens with MIGS is you turn the eye, and then that blood ends up kind of using gravity, mixes with this, viscoat that you have on the eye, and all of a sudden you'll end up with this really hazy view, and it's all from surface blood. So I'm just going to show you how this particular bleed that I showed earlier impacted things. You can see it's like this eclipse coming across the eye. I lift up my lens, and even though the anterior chamber is actually quite clear, I'm really not seeing a very good view. And it's not the end of the world. You just rinse it off. You put more visco on top, but especially those little bleeds, they can continue to bleed, and it's just much more inconvenient than it's worth. So I will actually purposely make my corneal incisions a little bit more anterior when I know I'm going to be doing an angle-based surgery. And then blood in the anterior chamber is a little bit harder, I think, in some cases to control, because some of this is patient based too. But when you start having a lot of bleeding within the eye, it can make your view more and more challenging. I think a couple of things that can be really helpful. Viscoelastic is very much your friend. Not only can it displace some of that blood when you get in a scenario like this where you can't see very well, but it can also help to pressurize the eye. A lot of the bleeding that you get from the anterior chamber is actually from reflux back into the eye when the pressure drops. And so keeping the eye pressurized can actually help prevent a lot of that bleeding in the first place. The other thing is if you're making, for instance, a small incision in the trabecular meshwork for something like a GAT, where you're going to go in with a separate tool, you don't want to wait a long time between when you make that incision and when you're using the next tool. You want to do them kind of back to back to kind of prevent allowing enough time for blood to build up. And then you want to give yourself some good landmarks in there. And one of the things that I like to use in poorly pigmented angles is trypan blue. Again, this requires that preoperative planning step, but if you know that someone doesn't have any pigmentation or trace pigmentation on the trabecular meshwork, it can be a really nice tool. You can see here that that nice blue line is now well delineated for my Cahook dual blade goniotomy. And sometimes, if you have a phakic patient, sometimes I'll use what I call like the blue donut technique, which I'm showing here, where I'm putting a little dollop of viscoelastic material over the lens, and then putting the trypan in the actual angle. But the one thing that I think, no matter what, if you're using trypan blue to stain the trabecular meshwork, you need it to give a reason to stain it. So it's unlike using trypan blue for staining the lens where you just need it in the eye. You actually need the pressure to be up to drive that trypan blue into the angle in order to actually allow the TM to uptake it. And then the last thing I always say is to be safe. There are potential risks with minimally invasive surgeries. It is called minimally invasive, but we do see risks with it. And one of the scariest ones I would say is a cyclodialysis cleft, because these can be very, very hard to close. And then anterior capsular rupture as well. So cyclodialysis cleft can cause a lot of visual morbidity and can be really challenging to treat. Often they end up with a vision worse off than you started. So we try to do everything we can to avoid that. And so if I'm in a position where I'm not sure if I have a good enough visualization, or if I don't have a comfortable enough position that I feel like I could potentially end up in a position where I'd cause a cyclodialysis cleft, I'm going to not stop where I'm at. Even if it means having a less effective surgery or a smaller goniotomy or stopping the GAT or canaloplasty early, I'll do that if I feel like that's going to be the safer move for the eye. And then the other thing is anterior capsular rupture. This is something, if you're especially combining, I say I do my angle-based surgeries before my cataracts, I just have to be a little bit extra cognizant of this when I'm going across the eye. And so I always go across the anterior chamber with my instruments before I put on the MAGE prism, because you can really lose track of where your instrument is as you're bouncing around the eye on the way over to the angle. So go across first, place the prism once you're most of the way across the eye, and then you should be in a safe position. So from the operative standpoint, I think kind of making sure you plan ahead of time, pick your patients wisely. And then when you're in the OR, make sure that they're positioned correctly so you're giving yourself the best view. Sometimes using things like trypan blue can really help with that visualization, but then avoiding things like cornea stria, blood, and then of course, above all, be safe. So thank you so much I have Dr. Allward next to me here as well. We'll be happy to take any questions.
Great, thank you very much indeed. Excellent lectures, both of them. I found them extremely enjoyable and extremely useful. And we have one question from one of our residents, which is, if we use vision blue during angle-based surgery, which structure will be stained beside the trabecular meshwork?
I find within the angle, it really should just be the trabecular meshwork. Of course, it will also stain the lens capsule. So, that's obviously the reason that it's there. But it won't, at least in my experience, it hasn't stained any other aspects of the angle. And so that's why it can be such a powerful tool, because it stains the exact structure that you're going to be addressing.
Excellent, thank you.
And I think Dr. Bassey's idea of this blue donut, she does surgery on our mycilin patients who are as young as 9 years old. And so we don't know what trypan blue is going to do to a 9-year-old lens. And so she puts this dollop of viscoelastic and carefully protects the lens before she drives up the pressure and pushes this trypan blue into the angle. I think that's a really, really important step.
Great. And Dr. Bassey, I've just got one question for you, which is, what's your preferred gonio lens for doing MIGS? And I had another question, but I can't quite remember now.
I don't even know what it's called. I think it's like a version of a Swan-Jacobs lens. I don't know specifically the same one that you would have been using.
Yeah, so Swan-Jacobs lens is sort of what we've always used.
Yeah, so I don't know the exact style or manufacturer that we use, but I'm pretty low tech. I just use a Swan-Jacobs.
And presumably when you're doing the surgery, then you're using some midricaine to dilate the pupil after you've done the MIGS? Or do you dilate the pupil beforehand?
I just dilate the pupil beforehand. I really don't think that it has impacted my view much at all. And like I keep saying too, sorry if I sound repetitive, but like, deepening the angle with the viscoelastic, you're working under pressurized eye, that it really doesn't bother me that they're dilated. And so so when I'm combining with MIGS and phaco, I will start with a dilated eye. Otherwise I feel like I'm going to be waiting in the operating room for quite a bit of time. I think more reason to make sure that you're not, bouncing around the eye when you're going across the eye with their instruments, making sure that you go across first, and then placing the prism is even more important because you don't have that iris protection.
Yes, yes. Okay. And we've got questions about vision blue here. How would you avoid staining the endothelium by vision blue? And does it stain Schwalbe's line?
I haven't seen that it stains Schwalbe's line. You know, I think that the driving force is, you know, pressurizing the eye, allowing it to start to drain out of the eye, which would then highlight the trabecular meshwork and underlying Schlemm canal. So I really don't see the other structures. It really is the same area that would be pigmented with enough time. And sorry, what was the other? Oh, the other area. So I don't really see that endothelium gets stained with trypan. I haven't really seen that. I know a lot of people will use like a bubble, for instance, when they're staining the anterior capsule of a lens. I've never really been in a position where I feel like the endothelium has taken up that trypan blue in any visually significant way. So I don't personally worry too much about that. But I think that the blue donut technique also will help at least protect that central endothelium too, if that is something of concern.
Okay, okay. And I had one question for Dr. Allward. You probably know that we have quite a number of patients with congenital glaucoma and some with juvenile open-angle glaucoma as well, who seem to get it typically earlier than we see in the West, and an abundance of CYP1 genetic abnormalities. So, you know, their angles can look pretty odd and sometimes difficult to figure out what's going on. What are the kind of typical abnormalities that you've seen in these angles?
Oh, well, I mean, I've been doing gonioscopy for 37 years, so I've seen every imaginable weirdness in the angle. And I think, you know, obviously these children, you're going to be operating on them early in life, doing goniotomy or trabeculotomy early in life. And you're not going to have the chance until they're older to do the slit-lamp gonioscopy. But I think if you are in the clinic and somebody who's older and has been through some surgeries, maybe, I really think the corneal wedge, I can't emphasize enough how valuable that is in these young people when you're seeing them in the clinic to sort out the anatomy. And as I said, you do it in the upper or lower mirror. You really can't do it in the side mirrors, but once you figure out the anatomy in one part of the eye, your brain you can sort of figure it out the rest of the way. You just want to figure out what structures what. So yeah, for these young people, I think corneal wedge really useful.
Okay, great. And we've got another question. Which surgical gonioscope is easiest to work with for a beginner?
You know, we often just have the one prism that we're using. Like I said, that there are disposable hands-free ones, which I don't have a lot of experience myself using. But because of some of those multitasking challenges that I think, especially early on in doing angle-based surgery, you run into, that I could see being beneficial, or like I said, having someone with more experience in there holding your gonioscopy prism for you. But I haven't used enough to really have a strong feeling, just because it would kind of use the one that's available to us.
Okay, that's great. Okay, well, I think that's all the questions that we had there. So I'd like to thank both of you for really giving us your time and giving some great lectures. And I'm sure our trainees have really benefited from them. And thank you very much.
Thanks for having us.
Thank you.
Excellent. Thank you. Take care now.
All right, take good care.
Thank you.